webinar. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, TNFOG with other societies. So let us start the webinar with Saraswati Vandana. It's my privilege to introduce the MOC of today's webinar, Dr. Madhumita Arun
Radhika Gauri. Madhumita is not there. Radhika Gauri.
Okay, ma'am. It's my privilege to introduce Dr. Radhika Gauri, ma'am. I'm a specialist consultant in OBG and clinical lead at the ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Good evening, respected faculty and respected Sampath ma'am, Anjalakshi ma'am, and Amala ma'am, and all our senior professors and all the faculties who joined from all the four societies. So we have yet another interesting program today, and I request Sampath ma'am to give an introduction, and please vote for Sampath ma'am. Elections are here, and she has guided us all the way through. All the 5-6 years she's worked hard, and I think she'll make a fantastic president and bring our FOGC to a greater level. So please vote for Sampath ma'am. I request Sampath ma'am, and I will.
Yes.
Yes.
Thank you, Radhika. Sagiti, you can put the flyer. I welcome you all for this TNFOG with the other societies program. Here we thanks to Dr. Anjalakshi Madam, the founder president of TNFOG, and the current president Dr. Amala Madam to be as the chief guest. And felicitations to the Udaipur OBGN Society President Dr. Sudha Gandhi and Secretary Dr. Nalini Sharma, and Alwar Society President Dr. Saroj and Secretary Dr. Ritika, and Rajmundri OBGN Society President Dr. Padmaja and Secretary Dr. Lalita, Bharuch Society President Dr. Hiral Pandya and Secretary Dr. Falguni Taka. Within the short duration, all the four society has accepted to join. And we have a talk on teenage pregnancy, not e-motive bundle. I think, sorry for this printing mistake. And we have the panel discussion on recurrent pregnancy loss. The pregnancy loss panel will be moderated by Dr. Meera Raghavan and Ramani Madam as expert. And we have a wonderful panelist, Dr. Falguni Thakur, Dr. Meenal, and Dr. Shravani, Dr. Brinda, Dr. Munisha, and Dr. Komadi. And I welcome you all the faculties and delegates for this TNFOG webinar, which is conducted every week. Normally, it will be on Tuesday. Today, this time it is on Thursday. And I welcome our first chief guest, Dr. Anjalakshi Madam. All of you, please vote for me. As Dr. Radhika told, I am contesting for FOGC President. Please support and vote for me. Thank you. Dr. Anjalakshi Madam is our founder, president of TNFOG and the past president of FOGC and a governing council member of DIPSI and life member of TAPISAR, PCOD, IMS. And Madam is our one of the PhD from our Chennai. She had her topic of PhD. Yes, of all this, Dr. Anjalakshi Madam and Dr. Amla Madam are the best human beings. Yes, Dr. Anjalakshi Madam.
Good evening. Good evening, Sampath and the other faculties and the delegates. I congratulate the TNFOG for this novel idea of conducting the webinar with other societies, 4 other societies today. And the topics are very important. The recurrent pregnancy loss, which is very important both for the theoretical aspect as well as the clinical aspect. And you are going to have a wonderful panel with to be moderated by Dr. Meera, and a robust panelists are there. So a lot of learnings will be there. So I wish a great success for this webinar and my blessings. Thank you for this opportunity given to me. Thank you.
Thank you, Anjalakshi Madam. Next, I welcome Dr. Amala Devi Madam. She is the current president of our TNFOG and founder, president and secretary and president of Dindigul Obedience Society, IMA secretary and life member. Madam is, whatever is happening in Dindigul, Madam is the founder for all the programs which is held in Dindigul. And she has received a collector award every year, and she is doing a lot of adolescent program, and she has made the HPV vaccination program successful in Dindigul, and a Lifetime Achievement Award during Foxy VP Conference and Lifetime Achievement Award by Alagasamy Memorial Trust. Welcome, Dr. Amla Madam. Yes, Madam.
Okay, good evening to everybody. This is I think this is the third or fourth webinar TNFOG conducting. TNFOG is conducting with other societies, and this is Udaipur, Rajmandri, Alwar, and then the Baruch. Now 4 societies have joined, and I welcome all the president and secretaries of these societies on behalf of TNFOG. And there is 2 talks. That is one teenage pregnancy by Sambat, and the other one is recurrent fetal loss by Dr. Ramani and Meena Raghavan. And then the speaker is Sambat for that first and the second one. Then the MOC is conducted by Madhumita and Radhika. I thank, and then I wish that Sambat will be the next president, coming president, and we pray and vote for, everybody should vote for Sambat, in not only in Tamil Nadu as well as the nearby states who are joined today also. You make members to vote for her. So I wish all the success for this webinar as well as for the victory of Sambat. Thank you.
Thank you, Amla Madam. Thank you, Amla Madam. Amla Madam is a current president and accepting for whatever program we tell, she will accept. Thank you for the nice words, Amla Madam. Now I request Alvar Society Secretary, Dr. Ritika, few words. Saroj Madam is there? Dr. Saroj? If not there, Ritika is there, I think, from Alvar Society. Dr. Ritika?
Leave me webinar cancel
Or else now we will go with the Rajmundri Society President, Dr. Padmaja. Dr. Padmaja, Padma Saja is the Director of Prakriti IVF and Laparoscopic Center and established the first IVF center in Rajmundri and obtained post-graduation from Usmania Medical College, President Foxy, Rajmundri, and Organizing Secretary for APCOG to be conducted APCOG in 2009. And again in 2000, now they are conducting the Yuva Foxy Conference, faculty of many CMEs and member of HP and Foxy, ASRM, member in ISAR. Dr. Saja Padma, few words for the blessing of the webinar. Welcome. They are doing a wonderful
Thank you, ma'am. First of all,
thank you.
let me thank you all for making me a part of this wonderful webinar. And at the same time, I'm very happy that you're contesting for presidential, upcoming presidential election. I know you are a great academician and dedicated Foxian. And from our society, we wish you to be a great leader in future years as a great Foxian. And we wish you all the success and all the very best, ma'am. And
Thank you. Thank you, Dr.
Thank you, ma'am.
Thank you for the nice words, Dr. Padma. Anyway, you be there. Dr. Lalita, are you there? If she is not there, we'll go to the Baruch Society President, Dr. Hiral Pandya. Dr. Hiral Pandya, CV of Dr. Hiral Pandya. Dr. Hiral Pandya is the president of Baruch OBGN Society. Madam, are you there? Dr. Hiral?
Yes, ma'am. I'm there.
Yes, madam, you open the video, we can see your face.
Yes, ma'am.
Yes, welcome. So a few blessings for the webinar, madam. Welcome. Welcome to this
Thank you,
webinar.
ma'am.
Thank you, Dr. Kiral. And Falguni, are you there? Secretary of Madam, you can speak few words, Dr. Kiral.
Ma'am, I'm very much thankful to the TNFOG for giving me the opportunity to be a part of this webinar. And it is indeed a very interesting topic. The same topic we had CME this Sunday about immunology of recurrent pregnancy loss.
Okay,
I have fallen in love with RPL.
Yes, yes. Now that Meera will conduct a wonderful panel. You can wait and see. Yes. Dr. Falguni, are you there? Yes, she is there. She was the first one to join. Few words, Dr. Falguni. Okay. We'll see. Alvar Society, Dr. Ritika, I saw her name. I don't know what happened to her. Dr. Ritika? I don't know. Say Dr. Ritika and Dr. Saroj. Ritika told she has joined. Anyway, we will start with the scientific section.
We'll start with the scientific session.
Kumari is not there. I told you, no, there was some family problem. She will not be joining. Aruna Kumari is not there. She was the past president of Rajmundri. Now we'll go with the scientific session. The topic is teenage pregnancy.
Yes, ma'am.
Yes, ma. I will share the PPT first. Yes, can you see, Radhika?
Yes, ma'am. You can see. PowerPoint.
Yes. Yes. Good evening to all, and I welcome you all, the delegates and the faculties, for this wonderful CME, which is, as Amla Madam told, this is our fourth CME with other societies. My topic is the teenage pregnancy, which is the burning issue of our situations. See, these are all the papers. 1,448 minor moms gave birth to babies in 3 years in LI. And similarly, in the teenage pregnancy crisis, we are talking about this for many years, but still the teenage pregnancy is continuously going on. See, globally, about 16 million girls aged 15 to 19 years give the teenage pregnancy. And 1 million girls under 15 years give every year the delivery. And mostly it is in the low and middle income countries. If you see this girl, she is only 20 years old, and this baby is her third baby. Here I was doing one counseling in a nearby place, which is the remote place. I did the counseling. Say every year I go to the place and do the every alternate 3 months, once in 3 months every year for the past 5 years we are doing the counseling. In spite of that, these things are happening. So how it has to be prevented? See, the adolescence, as all of us know, it is neither the children nor the adult. It is the duration between the childhood and the adulthood. And they do not know what to do. The adolescence is the early adolescence, middle adolescence, late adolescence. 10 to 13 years is the development of the secondary sexual characters. 14 to 16 years, they have the separate, they want a separate identity from parents and are attracted by the opposite sex. That is the reason we tell a sweet 16. In the late adolescence, they have the distinct identity and the well-formed opinion and ideas. The statistics about the teenage pregnancy, because somebody should guide them. If you don't guide, some adolescents know everything. Some adolescents, they do not know everything. How the pregnancy occurs also, they do not know. So it is our duty to streamline, because today's adolescents are future nation and future state, everything, future country. 2/3 are sexually active before. Whenever you go for the school counseling, you have to talk to them about the sexual health. because already 2/3 are sexually active before 20th birthday. And 49% of girls get married before 20 years. As per community, 10 to 40 unmarried have the unintended pregnancy. Similarly, the girls, they also don't know about, they end up with the unintended pregnancy. So the incidents, the complications during pregnancy and childbirth are the second cause of death for the maternal mortality. Around 3 million girls aged 15 to 19 undergo unsafe abortion. If a girl becomes pregnant, she do not know whom to contact. She cannot contact the parents, she cannot contact the teachers, and she do not know what to get the treatment. And how to prevent the pregnancy also, they don't know. So we have to talk about even the contraceptions when we go for the school counseling. In India, the teenage pregnancy constitutes 8 to 14% of the total pregnancies. Among the total pregnancies, what happens? They themselves are children. They do not know about the pregnancy. So around 27% end in abortions and 14% end in miscarriage. Only 59% becomes birth. Without accidentally, knowingly or unknowingly, they become pregnant. And most of it ends in the abortions. If they come to us, we can have a good guidance. But if they go to the unqualified person, again, the problem occurs. What are all the causes for teenage pregnancy, whether it is rural or urban? See, in the rural, mainly the poverty. When a girl attains menarche, they don't want her to continue in the house itself. They will get married immediately, whether it is 18 years or 19 years. Because of this early marriage, the schools are dropouts. Since there is no school dropout, they cannot complete the studies. Again, the poor educational opportunities, they don't know what to do. Once they get married, they will become pregnant. Unemployment and the failing nuclear families and abuse, child abuse. Again, the incidents, which is not present because most of them, they don't come out with that child abuse incidents. It is not reported. And the early menarche. Nowadays, the girls attain the menarche by 10 years itself. That is because of the lifestyle changes and also of the environmental toxins. And the domestic violence. These are all the causes for the pregnancy and the poor access to the health care. That is the poor access to the how to use the contraception, where it will be available. They do not know. And in the rural and urban places, what happens? Again, this is common everywhere. The rape, alcoholism, substance abuse, social pressures, and the low self-esteem. Because if a friend is having a boyfriend, she is also tempted. And she will also be willing to have a boyfriend. So these are all the social pressures. Most of the things the adolescent learn from the friends and from the social media. So always used to tell the parents should talk to the adolescents about the nutrition, about the PCOD, about the menstrual bleeding, and also about the pregnancy. How the pregnancy happens. Unless the sperm and the ovum unite, the pregnancy will not happen. Some girls, they ask, if a boyfriend kiss me, can I become pregnant? So we should take an opportunity. That is the dinner night. All of you should sit together and the parents should put a leading question to the children and clarify their doubts. And the influence of the media. If they get it from the media was very useful during the COVID time, because the classes were also be taken in the media, even in the government and in the private. But what they are doing, what is the password of our children, that should be, everyone should know. See, always I used to tell, take pleasure and pride in saying no when you want to say no. If a girl feels that a boy is following her, tell him no, that I have a lot of commitments to work. I want to become a so-and-so doctor, engineer, or whatever. Till my commitments is over, if at all needed, you wait. Otherwise, allow me to continue my ambitions and continue my commitments. So they should have in a polite manner, they can tell no to the followers. And similarly, the boy. All of us are very familiar of this Pinky movie. No means no. So whether it is a girlfriend or a wife or a sex worker, if a girl tells no, means they should not touch. This is the way we can reduce. So rather than becoming pregnant, we have to give them counseling and teach them how to prevent the pregnancy. This is our TNFOG Adolescent Health Program, which we did. During 1 month, all the societies did this program, and around more than 3 lakh adolescent students were educated. What is the result? They themselves are what to tell that teenagers, so they don't know what to do. So it is the many biological immaturity, unintended pregnancy. They do not know to feed the baby, inadequate perinatal care, Poor maternal nutrition, when an adolescent is 12 years, her hemoglobin should be 12 grams. If it is less than, means with the less hemoglobin, she will get married, and with that she will become pregnant. As all of us know, anemia is the first common cause of mortality in pregnancy. And the stress, again, this girl gets married at the young age, her friends will be going to the school and they will be going to the job. She will be under stress, do not know what to do. And she will become pregnant because the partner will be the senior age and he will be knowing the everything, and this girl will not be know about the contraceptive methods. The socio-economic deprivations. So as I told, because of the poverty, they get married and they become too early pregnancy. Because of this too early pregnancy, what happens? There is a loss of educational and employment opportunities. Again, the poverty. The cycle is continuous. So what are all the, why we are talking about this teenage pregnancy? What are all the complications with this teenage pregnancy? Antenatal, they have anemia, miscarriage, preeclampsia. These are, the girls are very innocent and they do not know, they do not check up the BP, they do not check up the hemoglobin. Finally, the preeclampsia incidence is also increased. And during the intranatal period, the pelvis is not developed, so it can be the cephalopelvic disproportion. And because of this, there can be an increased incidence of LSES, and they do not know the stages of labor. First stage, second stage, third stage, and they will not cooperate during the delivery, and that can lead to the traumatic fistulas. Sometimes the postpartum hemorrhage is also common. Postnatally, what happens? They are not able to feed the baby, and they will be depressed, and they have the psychological illness and the postpartum illness, and they do not aware of the postpartum illness, whether the bleeding, if continues, to go to the doctor, or if there is a pain in the leg, they should go to the doctor. These things they may not be knowing. So we have to give the counseling to the teenage girls. The neonatal, what are all the complications? Is prematurity, low birth weight, growth restrictions, and again neonatal mortality. Breastfeeding will not be sufficient, and the inadequate care, because she herself is children and she may not be able to feed. Adolescent pregnancy contributes to the maternal mortality, perinatal mortality, and infant mortality, and it contributes to the vicious cycle of the poverty. So as I told, this is the country-wise. India is having the low only, but still it has to be reduced. In India, Tripura is having the number of teenage pregnancy, Lakshadweep and Chandigarh is having the low, but in spite of that, the incidences has to be reduced. These are all the risk factors. The Smooth Lakshmi Reddy scheme in Tamil Nadu, I think in many states, during the pregnancy, they get around 18,000, 6,000 during antenatal, 6,000 during intrapartum, and 6,000 postnatal for the feeding purposes. But this Muthulakshmi Reddy scheme is not given for the teenage pregnancy, because this benefit is also they are not able to accept. Because we talk about the POXO Act that they should not have sex before 18 years. So the Muthulakshmi Reddy scheme is not given for the teenage pregnancy. So how to prevent this teenage pregnancy? See, you cannot talk just like that. You can become pregnant, so if you like that, talk to the children with the anatomical factors. That is the when they have the contact, sexual contact, and the ovulation that happens during the 14th day of the cycle, and how to avoid the sex during that time. We use the contraception. So talk to them in the anatomical facts and tell them how the pregnancy happens. So this information can be given in the schools by the mass medias and the parents and the community and the celebrities, VIPs, everyone can give the counseling such that the adolescents will be aware of the pregnancies. This is the parent-adolescent relationship education program. In this program, they talk about the prevention of STDs, not only the pregnancy. Again, HIV can happen. If you take HIV, about 40% of the newly detected HIV is among the adolescents. So the safe sex behaviors has to be taught to them. So how the safe sex behaves? We have to talk about the contraceptives, the tablets, injections. Now the Antara injections, that is the DMPA, is available even in the government hospital. That can be given once in 3 months, and the sexually active girls can go even with the contraceptives, and the copper T devices can be admitted. So the options has to be given, and the girls should know the how to prevent the pregnancy. This is the adolescent contraception, highly effective, protect against, always dual method is better to prevent the sexually transmitted disease. And normally, as per POX Act, we cannot give the OC pills for the adolescent girls to prevent pregnancy. So it can be given as an indication for the regularizing the bleeding and the pain for dysmenorrhea, endometriosis, and the PCOD syndrome and acne. With these symptoms, we can give the OC pills and counsel the adolescents not to become pregnant. Rather than becoming pregnant and going for the complications, to counsel them to not to become pregnant. These are all the recommendations. Whatever the available recommendations should be given to the adolescents, and the screening of the alcohol use and substance is very important. Nutritional assessment should be done because of the anemia and low birth weight can happen to the mother and to the baby. It is a multidisciplinary care. The gynecologist, anesthetist, and the pediatricians, everyone should be together. And all stages of pregnancy has to be explained to the adolescent. What will happen in the first stage, what will happen in the second stage, the delivery of the baby, what will happen in the third stage. If the placenta is not delivered, what will happen? So the risk has to be explained that adolescent antenatal classes is very, very important. And about the sexually transmitted infection has to be told. And the baby, again, they can go for the preterm labor, preterm birth, and preterm pre-rupture of the membrane. And the babies can have all the complications if they go for the preterm labor. So the conclusion is, rather than going with the complications of the teenage pregnancy, we have to prevent the teenage pregnancy by educational programs for children and adolescents and programs to improve the access to contraception. They do not know where to go to get the contraceptions, where it is available. It has to be the comprehensive healthcare education should be done in the school and by the NGOs and by the societies and by our gynecologists. And the programs geared toward educating parents, not only the children, we have to educate the parents, and we should also educate all the family members that not the teenage girls should not get pregnant, get married and pregnant. They should educate them. Always the school girls should be educated at least to a degree level. Then only we can avoid this teenage pregnancy. It is a multi-component program. Youth development programs has to be done. Complications of adolescent pregnancy should be explained, and routine antepartum, intrapartum, and postpartum care should be given to the teenage pregnancy. And thank you for this opportunity. And I request all the delegates and the faculties to support me and vote for me. Only 1 week is more. The election starts from August 1 to 10. Don't be idle. All of you, please vote. Most of the time, our percentage is only 40 to 60%. This time, at least 70 to 80% should be there. Please vote for Professor Sampath Kumari. Thank you.
Thank you, madam. Thank you, madam. So it was a wonderful presentation, ma'am.
Now we will go to the
need of the hour. Yes,
yes, Radhika, you are telling something.
Yes, ma'am. It is a need of the hour. I said teenage pregnancy because of the internet and everything. Everybody wants to get married quickly. The younger girls, as soon as they finish 12th, they get love marriage and all these things. We all faced, especially in Tirunelveli. As you said, it's higher incidence, ma'am.
Nowadays, marriage is not at all an indication for pregnancy. Whether married or unmarried, this teenage pregnancy has to be avoided.
Yes, ma'am. Absolutely.
Okay. Amala madam, do you want to tell anything? Amala madam, unmute பண்ணுங்க. Unmute பண்ணுங்க, madam. You are muted.
I came to know that Sampath is doing, and she is caring for these adolescent girls for more than 10 to 15 years. Every there will be all conferences, there will be a talk about the adolescent. Mere education, awareness creation among the public as well as the parents. They should, because of all these medias, social medias, this is going up very high. Teenage pregnancy is going up very large numbers. Sometimes we may not confuse ourselves what to do for the children. So mere education from all sides, the NGOs, doctor, medical society, and everybody should take care and see that. Let her go, at least have the boyfriend, but she should know that what makes her becomes pregnant. Most of the girls come and tell us that he had given some drinks, cool drinks, I took it, and then he had given some food, I ate, and then I became pregnant, which is very, everybody will be laugh at the statements given by those girls. most of them are not aware of their body itself. There is some in colleges we ask you. I used to ask where is your uterus. One patient was telling, one girl was telling it is from the epigastric region. She showed, and some of them showed in the right and left kidney side. They said so. Most of the girls in school curriculum, I heard that the teacher just to omit the reproductive system topic itself, they don't want to teach them because they are themselves not knowing about this reproductive system. So school, should be a curriculum added regarding this. In younger ages, when we were young, they will be very hesitant. Parents won't tell the children, teachers won't tell, and the society is not going to give them education regarding their maturity, and then when they will become pregnant, if they got a contact with a person, male person. So all these should be brought up in our curriculum, and then the society, the maximum medical persons, so whoever comes to the lower village nurses and everybody should be made to teach these young girls regarding this, so that we can prevent and prevent mortality also.
Thank you, madam. Thank you, madam. Dr. Hiral has joined, I think. Dr. Hiral, would you like to tell? She has faced her. Yes, we'll go to the panel. Thank you, Amla madam. Really, as a TNFOG president and a secretary, we will do a great thing and we will try to reduce.
Because I work in a very small town in Gujarat and I
Yes,
face such
yeah.
issues very on and off. I get
Ah.
married patient of 16 years, 17 years also.
Very
Pregnant
bad.
married patient.
So we have to talk about the contraception, but we cannot prescribe what to do. We will form some guidelines, madam. Definitely. We will form
It has not reached to the reachables. It is there only till only in the towns.
Towns, in the small places,
Yeah.
it has to be done. We will do it together.
Ma'am,
it's not uncommon. It's not uncommon. There are girls from Northeast who come for fertility treatment because they are married already for 3 years. I tell them, you should thank me that I am not reporting to police. Please go back.
No. You have to report. Otherwise, you will help.
Definitely. But they are married already for 4-5 years and they think that is infertility.
Ma'am, they come with government Mamta card number also. Government knows that they are 16 years and they are pregnant. What we will do if we inform the police?
If the Mamta card number is given means we don't need to report to police. If they are coming to us, it means we have
That's
to
what
report.
I'm saying. The card
government
number is
officials
there.
are not working on it. They are continuing with their 16, no counseling,
This
no
is a very
follow-up,
common
nothing.
scenario.
We will do, madam, with Foxy, from Foxy, we will do. I have a lot of information from every places, we will do. Now we will go to that panel. Yes, Radhika. Dr. Meera Raghavan.
Yes, ma'am.
Yes, ma'am.
Ma'am, sorry, I would just like to add one point. Hello.
Yes, madam. Yes, tell your name. You didn't change your.
I'm so sorry. My name is not coming. I'm Dr. Meenal Chugh from Udaipur, Rajasthan.
Yes,
I'm working in
madam.
a government hospital, ma'am. Hello, ma'am. I'm working in a government hospital, ma'am, and we see these kind of cases daily. People, even 13, 14 years of age and having full-term pregnancies, they come to us almost on a daily basis. And we have a very good system. We get all MLCs done for such patients. But the problem is that there is no active participation from the government side, because even if they are less than 16, let alone 18, it is very casual in our place. They just go to the police station and the relatives say that we are married and we are not having any problem, and the police people also don't say anything to the relatives. So ma'am, as you were saying, that if you can do something in this regard, even if the age can get relaxed till 16, that will also be a very big step. It will at least reduce the load of MLCs to half in our setting at least. But below 16, if some action should be taken, and it is not being taken right now, at least in our place. So ma'am, if you can do something regarding that. Thank you.
Definitely we have to do this. POXO Act is only in India, not in abroad. So this age relaxation we have to do. We will do it. We will try to do that. Thank you, Dr. Meenal.
Thank you, ma'am.
Yes, Radhika, introduce the moderator and the panelists.
Yes, sure, ma'am. Thank you, ma'am. Now we'll move on to the next session, which is the panel discussion. I welcome Dr. Meera, ma'am, who's our famous consultant gynecologist and robotic surgeon from Apollo. She's a proctor and trainee Hugo, RAS robotic platform, and convener of TNFOG certificate course in Eurogynae. The board certified lifestyle medicine physician, National Board Specialist Committee member, treasurer of SOFC TN chapter, core committee faculty, Eurogynae committee FOGC since 2015. And she's one of the scientific chair of AACC RCOG 2025, a national board coordinator and examiner, MRCOG trainer and an examiner, and she's the director of ASCOTT Apollo Simulation Center coordinator for obstetric skills. And
Radhika,
winner
with
of
this ASCOT Apollo simulation process only, we did many program in Tirunelveli, Tanjavur, Tiruchi, with this ASCOT only.
Yes, ma'am. And winner of 32 gold medals in undergraduate curriculum and best outgoing PG student from PG IMR Chandigarh. And
yes, Radhika, among this you can add best instant moderator.
Instant. It's our Ramani ma'am. Yes,
Ramani madam has not joined, I think. Anyway, when she joins, we can take her. She is the past president of TNFOG and person of endometriosis. Introduce the panelists.
Yes, ma'am. We have Dr. Falguni Thakur. Good evening, ma'am. She is an excellent academic career. She is a gynecologist from BJ Medical College, Ahmedabad, with gold medal. Passed in 2000, MBBS from MGA Medical College. Received 5 gold medals. And senior consultant gynecologist in Mother Care Hospital since 23 years. Secretary of Baruch Obstetric Gynae Society. Past president of IMA Baruch. Scientific committee chair for state conference SOGOG 2024 and local state joint secretary in SOGOG 24 to 25, trained at Gynae Academic, Bangalore for fetal medicine and gynae ultrasound. And she's also a fetal medicine specialist, certified sonographer, special interest in gynae ultrasound, fetal medicine, and high-risk pregnancy. Delivered a number of lectures at national, local, state conferences. We welcome you, madam. And we have Dr. Meenal Shuk, who is another gold medalist, and she's a laparoscopist as well, consultant laparoscopic surgeon from Kalpana Nursing Home in Udaipur from March 20. And she's an assistant professor of Obs and Gynae Department, Pacific Medical College Hospital, Bedla, Udaipur from December 2020. And she's her memberships are life member of IMA and member of executive committee of IMA 2022 to 26. Member of FOGC Udaipur branch and treasurer of Udaipur Obs and Gynae Society from 2006 to 28. And she's a life member of IAG and ISAR. Welcome, madam. Dr. Gomati is a consultant obstetrician and gynecologist, currently assistant professor of Mada Medical College, Kundratur. She's been an assistant professor from Government Stanley Medical College, visiting consultant in Bevel, Sudarshan and KC hospitals, former assistant professor in RSRM, Chennai. She's done her UG from KMC and PG from Stanley Medical College, and she's an Oxy Life member. She won Esther Gold Medal Award. Special skill in high-risk pregnancy, infertility, laparoscopy, and colposcopy. And we have Dr. Monisha, assistant professor at Sri Muthukumaran Medical College. She's done her MBBS from Government Thuthukudi Medical College and a post-graduation from Government RSRM Medical College, Stanley Medical College, and a DNB as well. And she's presented papers in national conferences, published articles in national and international journals. And her areas of interest are high-risk obstetrics, minimally invasive gynecological surgeries, and infertility. We welcome you, Dr. Monisha ma'am, and we have Dr. Brunda with us.
Oh, Radhika, Dr. Brunda is not there. She is having some fever or something. You called Vinjamuri.
Okay, thank you.
Shravani Vinjamuri, have you introduced?
No, ma'am, not yet.
Dr. Shravani Vinjamuri. Welcome, Dr. Shravani. Yes.
Good evening, ma'am.
Good evening.
Yes.
Dr. Shravani.
Meera, you can start. You have Minal, Thakur, and
Dr. Falguni, Dr. Minal, Dr. Gomati, Dr. Monisha, and Dr.
Shravani.
Vinjamuri. Yeah, Shravani. Got you, ma'am. Thank you. Can I share my presentation? Yes, I've already sent it. So,
Who is presenting? Sahiti, are you presenting?
I'm doing, ma'am. I'm doing.
Yes.
Yeah. So today's topic will be a panel discussion. I'm sure all of you are experts in this. And mainly to understand the major cause of recurrent pregnancy loss and how we practice evidence-based approach. We cannot dish out all investigations for everybody or, keep on doing circlage for everybody. So there should be a logistic approach to the evaluation and management of recurrent pregnancy loss. And that is why we're going to discuss management of common scenarios like this. And also we will encourage a lot of interaction and discussion as well. So according to the various guidelines, is defined as a spontaneous pregnancy loss before fetus achieves viability. All pregnancy losses from conception to 24 weeks come under this umbrella term. We now have significant advancements in neonatal care, which have reduced the baby's survival before 24 weeks. So that way, we do not have much of a problem beyond 26 weeks. Yet, the morbidity is very high with preterm labor, as we are all aware. So primary recurrent pregnancy loss without previous viable pregnancy, whereas a recurrent RPL will include loss of 2 or more pregnancies. So a diagnosis of such should be entertained if there is 2 or more losses. And the good news is in majority of them, no cause is found, and that is given a terminology unexplained RPL. Why all this is important? It's important because nowadays women start their reproductive career much later in their life in a chronological manner. And even one pregnancy loss is considered a disaster. This amount of information with the right evidence is quite reassuring for the couple that it might not be recurrent. And even if we find a cause, there might not be treatment for that particular cause. It's just a association and might not be the reason for the recurrent pregnancy loss. This is what the important crux for counseling is. So all the major bodies of the guidance formation have agreed basically, ASRM as well as ESHRI, which is the latest guideline, have agreed to evaluate after 2 or more pregnancy losses. RCOG is still a bit conservative because it deals with the NHS, which is resource-oriented or funding-oriented. They have pushed the guideline to classify and evaluate recurrent pregnancy losses only after 3 or more such losses. Our FOXY CGPR also recommends evaluation more than 2 or more. And it does affect 1 to 2% of the couples, which is a severe psychological and emotional impact. And therefore, early evaluation is necessary to channelize your counseling and improve the outcomes as well. So we have various risk factors and health behavior, which are definite for everybody. So BMI reduction or optimizing the BMI is important. Quitting tobacco of any form is mandatory, and stopping alcohol is crucial. There are various factors which causes RPL, and I have enlisted a few. So as a guidance to our panel discussion, we will go through a stepwise approach of a detailed history, basic lab tests, uterine imaging, genetic evaluation, screening for APS in appropriate situation, and formulating an individualized treatment plan. So first case for Dr. Thakur. A 28-year-old woman, 3 miscarriages at 7 to 8 weeks, no previous medical illness with normal menstrual cycle. Madam?
Yes, ma'am. So
Yeah.
the miscarriages are at 7 to 8 weeks. That means very early miscarriages. Usually it is observed that this is mainly due to chromosomal abnormalities.
Yeah. So what is the most common cause, and should genetic testing be performed? And when
So,
would you consider parental karyotyping?
okay. So, ma'am, the most common cause for early miscarriage is chromosomal abnormalities. CMA of the products of conception can be done, but it is best performed after 2 or more abortions. So the first abortion, I would just counsel them that each and every time it's a new egg, each and every time it's a new sperm. So no need for doing anything, because every time it's a new chromosomal structure. But if it's more than 2, then I would go for
Yeah, she's already had 3. So
yes. So I would go, yeah. So I would go for CMA of the products of conception, and along with it, I would do the parental karyotyping also.
So for this particular case, because it's more than 3 or more than 2 itself, we would perform a CMA. What
Yes.
do we expect and how do we send for CMA, ma'am?
So usually what we do is that we usually would like to do it under sonography guidance. And once when I'm doing my termination of pregnancy under sonography guidance, I can feel that when it is coming out, the products of conception, I would send it in normal saline, or else whatever suction and evacuation products are there,
Yeah.
which is collected in the jar, I would wash it a number of times, and then that product I would send it in a normal saline.
Yeah. Note the point, it is normal saline. It should not be sent in formalin like a histology sample. So this
Yes,
is the
ma'am.
message we want to tell everybody, ma'am.
Yes, ma'am.
Yeah. Yeah. And when should parental karyotyping be considered? Like in this case, you have mentioned, what is the importance of CMA of the products? What is the importance of the parental karyotyping, which we do?
Okay, so if there is any abnormality in the parental karyotypes, I would tell her that there are the chances of still more recurrent abortions are higher. But if the parental karyotyping is normal, then I would reassure her again that it's okay. You still have very good chances say that your next pregnancy would be normal.
Absolutely. If there is a defect in a parental karyotyping, what will be the counseling forward step for this couple, madam?
I would give her both options, uh, and then in the cafeteria method, and then I would help her select. First thing I would tell her is that you again keep a gap of 3 to 6 months, lifestyle modifications, folic acid for both husband and wife, and I would try her to plan again. Otherwise, you can go for IVF, and then you can do the pre-implantation genetic testing, and then select the good embryos and put it.
Absolutely, ma'am. That would be probably also on the cards, because every miscarriage does have a severe emotional impact and a psychological setback for the couple. So if we find something abnormal in the parental karyotyping, yes, of course, they can go in for natural conception and await. Or else, if they are determined they do not want yet another disappointment, we can always give them the option of IVF with PGT for selection of a healthy embryo. Thank you, ma'am. Any other tests would you be performing on this couple?
Yes, all
Or
the
this
routine
lady?
the routine tests which we perform, like the thyroid function test, both the TSH and the thyroid antibodies.
Yes.
Her
What antibody,
diabetic,
madam?
pardon, TPU antibodies.
Yeah. Yes.
And just because it's already 3 abortions, and the patient is obviously she will be very anxious, so I would like to go for antiphospholipid antibody screening also, the lupus anticoagulant and the ACA.
Okay, thank you. Now, in this particular patient, the products of conception reveal trisomy. So most early miscarriages are invariably due to sporadic chromosomal abnormalities. So if this is coming, what will be the next counseling aspect and what will be the prognosis, madam, for her in future pregnancies for a live birth?
Trisomy does not recur, so I would tell her that your chances are good. You can try again, and there are all the very good chances that your next may be good.
Yeah. So she definitely needs counseling and more of reassurance. And as we already discussed correctly, natural conception versus IVF with the PGTA. And we will reassure the couple saying that prognosis is generally favorable and bright for having a live birth.
Yes.
So this 3 questions for you, madam. for deliberating on what is the right pathway. If such a scenario would happen today in your clinic, would you offer POC on a routine basis after this miscarriage? This particular case, if she was to walk through your clinic?
Yes, ma'am. I would always
Yes.
tell her that you have a option of uh, products of conception testing, because the main question in the patient's mind is, "Aisa kyun hua? Why did this happen?"
Correct.
So I can tell her
Yeah.
that this will give you the answer.
Answer.
As far as
Correct.
the
She's
second
seeking for
question,
answers. Yeah.
yeah, yeah. But then again, if she's not a very affording one, I would say it's okay. You can leave it. It's okay. Does not matter. Now, coming to the
That was
second
exactly the
question.
thought. Yeah.
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 Now, the second question, when should IVF with PGTA be recommended? Again, the cafeteria method, I would tell her go for I would explain her both the options. I would also tell her that all IVF pregnancies you will not conceive. Secondly, the cost factor is also there. So
Correct.
then I would help her decide whether going for a spontaneous one or a IVF with PGTA.
Yeah. She's
It's not
28, so
mandatory.
this cafeteria is there. What if she's 33?
Mm. Maybe I would tell her, okay, let's go for IVF.
It'll jump
We
the
will,
queue, basically.
yeah.
Yeah.
So
Yeah.
that, yeah.
So multiple factors, no ma'am, when we consider these options, it is the patient as the whole
Tailor-made.
rather than this event, which we will consider for future prospects as well as counseling. Thank you,
Yes.
ma'am. Thanks for that clarity. So
Thank you,
in
ma'am.
this particular case, would you reassure or intervene at this stage? She's already had 3 miscarriages.
Still reassure, because
Thank
in
you.
my last
Thank
25
you.
years practice, I've seen so many patients who have got 4, 5, 6 abortions. They are not so affording. They try again and it goes to
They will
term.
get, yeah.
Yeah.
So the age is on our side. So under
Yeah.
30, I think reassurance will be the first step. Yeah.
Yes, ma'am.
Thank you.
Yes.
Thanks a lot.
Thank you, ma'am. Thank you, ma'am.
So take home, chromosomal abnormalities are the most common cause of any early miscarriage, and genetic counseling is essential. And most couples still will achieve a successful pregnancy because these are sporadic in nature. And if the parental karyotyping is normal, they do not necessarily carry a recurrent risk of such problems. So reassurance is the first step forward. So in treatment of RPL with a genetic background, all couples with results of an abnormal fetal or parental karyotype should receive genetic counseling. Inform them about all the possible treatment options. So natural conception with prenatal testing, or an IVF with a PGT, a gamete donation or an egg donor or a donor sperm pregnancy, and even adoption, depending upon the age as well. So PGT could reduce the miscarriage rate, but it necessarily does not improve the live birth rate or the time to conception in the first place. So case number 2, I think I will put it forward to Dr. Minal. 32-year-old woman, 3 miscarriages at 10 weeks. History suggestive of thrombosis.
Yes, ma'am.
What are the possible investigation you would do?
Ma'am, first of all, I would like to rule out antiphospholipid antibody syndrome. So we'll do the 3 components which are used to rule out that syndrome. Basically, anti-cardiolipin antibody, anti-beta 2 globulin antibody, and glycoprotein antibody, sorry, and lupus anticoagulant. So if these are positive, then we'll repeat this test after 12 weeks. And if 2 positive readings are seen, then we can go ahead with the treatment for this patient. So she has already had 3 miscarriages, and it's approximately at 10 weeks of gestation. So we can start her on a low dose aspirin, even preconceptionally as well. And whenever she comes with a pregnancy and we see a cardiac activity positive scan, after that we can put her on low molecular weight heparin. Depending if we are giving it prophylactically, then the dose will be a little different, a little less. But in this patient, if it is already positive, then we'll give for 1 milligram per kg body weight. Can you hear me?
Yeah,
Yes,
she
1 milligram per
definitely
kg.
has Yeah,
Yes,
she
per day.
definitely has persistent antibodies. So we've diagnosed APLA syndrome. So as you rightly put, low molecular weight heparin, low dose aspirin, and close obstetric monitoring. What potentially she could face after crossing that initial period of miscarriage viability?
Ma'am, initially, as in when she crosses the 10-week this time in the fourth pregnancy,
Pardon? Yeah.
So basically, when she has already crossed those 10 weeks, we'll still continue with the heparin and the low molecular weight heparin till at least with the aspirin and the low molecular weight heparin till at least 34 to 36 weeks of pregnancy. And then we can stop that because if it is positive, then we have to give it on a daily basis as well. I would like to just add that aspirin I generally prefer to give in 150 milligram per day.
Yeah.
Low
Agreed.
dose, it is not considered to be 75 milligram because
It
I
is
have
not.
seen in my patients as well that when we give 75, they still, one patient still came with second trimester spontaneous miscarriage as well. So we
Yeah.
should give 150 milligram only. And some people recommend alternate day or even every fourth day low molecular weight heparin. But I think a daily dose is
Daily
better.
dose. Yeah.
Daily
And
dose is definitely
I
better.
specifically put some other caveat on the first slide. Sorry, had to go back. This also is there.
History is also suggestive of thrombosis. Then we'll definitely continue the low molecular weight heparin till at least 36 weeks of pregnancy.
And beyond as well, ma'am, in the postnatal,
In the
because
postnatal period as well, in the puerperial period as well, we'll continue
Yeah.
the heparin.
Yeah.
Ma'am, I have seen one such patient a few days back only. We had the patient didn't have any history of thrombosis before, but we had put her on low molecular weight heparin for APLA positive, and because of loss of follow-up, she didn't come to us in the postnatal period, and she came to us directly on day 25 with a thrombus in basically a
yeah.
DVT formation. So we should
Yes.
definitely
Yes.
continue it in the puerperal period.
Yes.
Aspirin, we can give 150 milligrams once at bedtime, and it is better to be given at bedtime because the
Yes.
platelet activity is maximum in the morning. So that is
Correct.
controlled because of the bedtime dose. And there is, as such, no role of HCQ. It should only be given if the patient is having SLE with APLA positive. Otherwise, as such,
Correct.
we do not give HCQ in
We do
those
not
patients.
give. Correct.
Yes, ma'am.
So, should all RPL patients be screened for APS?
If after 2 losses, then definitely yes. Not before that, no.
Yeah, agreed. So APS is the most treatable cause of
Treatable
recurrent
cause, yes.
pregnancy loss, and it is a proven thing by various evidence bodies that combined aspirin and low molecular weight heparin significantly improve live birth rate, provided it is a confirmed diagnosis of antiphospholipid antibody syndrome. So this has to be borne in mind. If there is a history of past thrombosis, you continue the heparin prophylaxis till 3rd month post-delivery, or if there is no such history, up to 6 weeks postnatally, because anyway, postnatal period is a high risk for developing DVT and PE, much more than in pregnancy, especially in the presence of antiphospholipid antibody syndrome. So our monitoring, surveillance, management does not necessarily stop with antenatal period and delivery. So that is the point I would like to emphasize here. The next.
Ma'am, can I just add one more point?
Yes,
Getting
ma'am,
aside from
please.
this, we should definitely avoid implant or DMPA injections for contraception in these patients as well, because they can also lead to more thrombus formations later on.
Yeah. Yes. And also be aware naturally of contraception with hormonal preparations, because they are prone for these complications. Very, very important. We thank you for pointing that out and reiterating. Our management does not, again, stop with looking after pregnancy. It is about contraception and continuing the well-being as well. So thanks for re-emphasizing that point, ma'am. Thank you. The next case, can I give it to Dr. Dr. Shravani is here. Dr.
Yes, ma'am.
Shravani?
I'm here.
Yeah, thank you.
Yes, ma'am.
29-year-old with 3 miscarriages yet again, and ultrasound suggests uterine anomaly. So
Yes, ma'am.
this is what we have in this scenario. What are the best investigations as to find out the nature? This is not uncommon. We get a lot of people saying metroplasty, septoplasty. How will we are seeing for the first time this patient. She's already had opinions outside. What will we do to make sure that there is an abnormality?
According to ASRM and ESHRE guidelines, ma'am, the 3D ultrasound, when performed very well and accurately, it rules out 99% of the uterine anomalies, ma'am. According to RCOG guidelines, hysteroscopy can be done, and saline infusion sonography and MRI pelvis also can be done in few cases, ma'am.
Yeah. Now that we have done a very good 3D ultrasound, we got a septate uterus as the picture here. So what
Yes,
is the causal association of this anomaly with regards to these miscarriages? See, just because something is present, it need not be causative factor, correct? So, but
Yes,
we
ma'am.
have found septate uterus on 3D ultrasound. What is
Yes,
your final answer on the septate uterus as being the reason for the miscarriage?
If I have ruled out all other causes for the RPL, ma'am, then I would explain to patient that the implantation might have occurred on the uterine septum, which is very thin, which is very avascular, and it may
Correct.
lead to recurrent abortions, ma'am.
Absolutely. So it does not have the capacity to cause proper implantation. Therefore, implantation failure or implantation difficulty can be there, leading on to miscarriages as well. Even if the patient wants to go for a ART, would you be operating on this patient? What will you do with regards to this particular thing?
Yes, ma'am. If I have ruled out like all other causes of the infertility, then I would like to go for a hysteroscopic septal resection, ma'am.
Absolutely, because it has been proven to cause improved outcomes of reproductive techniques. Yes. So in hysteroscopic septal resection, what important technical aspects would you want to emphasize? How will you follow up this patient? What will be the safe interval to get pregnant?
First of all, it depends upon how much amount of septum we are resecting, ma'am. We have to make sure that we are not going too close. Like we may rupture the uterine, we may rupture the fundus of the uterus, and we have to keep her on Progainova, ma'am, 2 mg BD at least for 21 days. And we have to ask her to come after 1 month, ma'am. And we have to ask her to report if there is any pain abdomen or any bleeding per vagina following the procedure, ma'am.
Yeah. Is there a role for IUCD to be placed?
I think the IUCD, copper IUCD was placed previously after resecting all the Sainik and Asherman syndrome, ma'am. To
But
prevent
not in a septal resection.
not in the septal resection, ma'am.
So what we can do is avoid unnecessary energy devices in the septal resection and use cold scissors, or now we have true clear kind of, mechanical resection. So those can be used to prevent unnecessary endometrial damage. And as you rightly put, Progainova, which is estrogen 2 milligram, can be given, and that will keep the cavity patent and helpful. How good is the interval with regards to a subsequent pregnancy?
I think we have to ask her to wait till 6 months, ma'am.
Okay. Okay. At
3 to
least
6 months.
3 to 6 months would be generally given, because at least 2 proper periods and then subsequently trying for pregnancy. So we've already discussed that which imaging modality do you prefer? A very good 3D ultrasound. If that does not pick up, an MRI would be done. Should all uterine septa be corrected?
No, ma'am. We have to rule out all other causes. Like the cause may be hyperprolactinemia or she may be a diabetic. So rule out all other
Right.
causes. Then we have to take the surgery, ma'am.
Yeah. What is the risk of surgery? What is the risk of
We may
surgery?
cause uterine perforation, iatrogenic uterine perforation.
Absolutely, absolutely. So it is not foolproof that the surgery itself will be beneficial. We need to kind of balance the pros and cons of the surgery and subsequently get going. Thank you very much on that. So the take home is septate uterus is a correctable cause of RPL, and hysteroscopic surgery improves the live birth rate according to ASRM as well as ISHRI guidelines of 2022. Thank you, Dr. Vinjamuri. That was wonderful. The next question would be going to Dr. Gomati, as in case 4. 35-year-old woman, 2 miscarriages, and symptoms suggest hypothyroidism.
Yes, ma'am. She is 35 years with the 2 miscarriages, so she needs RPA level evaluation. But still, her hypothyroid means, so we can test for anti-thyroid antibodies, anti-peroxidase antibodies, as well as we can screen for blood sugars and other endocrine abnormalities, obesity, lifestyle modification, everything, ma'am. So anti-TPO antibodies is must.
So now with the back and forth definition of hypothyroidism and evaluation, fertility and pre-pregnancy, what is the cutoff you will be comfortable, or when will you start thyroid medication? TSH.
So when the yes, ma'am. If the TSH, if the patient is present with anti-TPO antibodies, it causes 2 to 3-fold increased risk of miscarriage, but the causation is not proved. So if the patient is TPO positive and her TSH level is normal, euthyroid, we can just follow up her. If the patient is having TPO positive and her TSH level is high, so even the subclinical hypothyroidism must be treated, and she should be followed with TSH every 6 weeks.
Yeah. And TSH
So that
4
cutoff
or
is
2.3?
TSH is cutoff is if TPO positive, we can treat and keep it as less than 2.5. If TPO negative, we can have the cutoff of TSH more than 4 is good enough.
Less than 4 is good enough.
Less than 4, yes.
Yeah. So in the deciding factor would then be the TPO antibodies. We were probably much more aggressive in the past that we put everybody less than 2.5.
Less than 2.5. Yes.
Yeah, we didn't have it as less than 2.5. We treated everybody.
Nowadays, the CMONC center are for, even if we suggest TSH less than 4 is okay, but still on auditing the maternal audit, they still ask us, force us to put for even TPO antibodies for negative with the TSH less than 4 also. They are still, madam, it is TSH is more than 2.8. Please put thyroxine. They recommend, they ask for us.
Yes, yes. See, for that matter, even TT dosing is given 3 doses when actually the recommendation is 1 Tdap dose at 27 weeks. It will take some time for us to kind of change that, I think. So, but thanks for that clarity. Very nice. So, is hypothyroidism, if we find hypothyroidism, does it mean you have to do anything or just treat and wait?
Yes, ma'am. It is a risk marker. If the TPO antibody says that she is some autoimmune positive, there is some autoimmune dysfunction. There is inadequate thyroid adaptation in the pregnancy might cause miscarriage, and it can be another extra autoimmune factors can be there. So it is a risk marker, but not the direct cause.
And what will be the dosage generally we start the thyroxine, and what are the instructions which will be giving to the patient?
So the dosage is according to the body weight, 0.1 microgram per kg per day. We should be started at empty stomach and early morning with 1 hour of minimum without taking any food.
Yes.
1 hour
So
empty
at
stomach.
least an hour empty stomach before they have their first coffee, milk, whatever, so that the absorption is better. So
Better.
when will you perform a repeat test to make sure it is coming to normal?
After 6 weeks, ma'am.
Yeah.
Every 4 to 6 weeks.
Levothyroxine. Yeah. So
Levothyroxine.
ideally, if they are established hypothyroidism, at least every trimester. Otherwise, till you get a reasonable level of where it stabilizes, do it every 6 weeks. Should subclinical hypothyroidism be treated? And what is subclinical hypothyroidism?
Subclinical hypothyroidism is that T3 and T4 levels are in normal levels, only the TSH level is high. So that is the lab values
Absolutely.
of subclinical hypothyroidism. But should we treat subclinical hypothyroidism? The answer is if the patient is having recurrent pregnancy loss or if the patient is having infertility, we definitely should treat.
We should treat it. Yeah.
We should treat.
So, yeah. Do thyroid antibodies affect the risk of miscarriage per se?
Yes, ma'am. This actually the study says that the women positive for TPO antibodies have 3 to 4-fold increased risk of miscarriage, but the causation is not proved, ma'am.
Yeah, they're associated, but not necessarily a causal association.
Causal, yes.
So therefore, it is important to monitor and make sure their hypothyroidism at least is treated. Thank you.
Yes.
That was really, really clear. So I've just put it together, the tests which are not recommended at all according to the various guidelines. So there is a causation association factor, but the only treatment is metformin. You continue the metformin. Similarly, we do not recommend regularly testing for fasting insulin, androgen, free androgen index, elevated serum, prolactin, ovarian reserve, all these. There is no indication to routinely test them in patients with recurrent miscarriages because they are not of any benefit in forming any clinical assumptions and do not translate clinically into therapeutic benefits. So this is the guidance with regards to treatment of RPL with metabolic and endocrine abnormalities. For overt hypothyroidism, before conception, treat with levothyroxine. Subclinical treatment may reduce the risk of miscarriage. Once pregnant, recheck by 7 to 9 weeks. Thyroid autoimmunity, if it's euthyroid, do not treat. Once pregnant, recheck TSH. And then every 6 to 8 weeks, like doctor had already explained. So this I put together again the evidence with regards to the metabolic and endocrine abnormalities, luteal phase insufficiency. Progesterone alone has not got any sufficient evidence. Similarly, repeated HCG injections also have not proven. Majority of the fertility experts do that. Ovulation, induction, and PCOS, again, evidence too limited. Metabolism, with regards to glucose metabolism, metformin, again, insufficient evidence. Consider supplemental vitamin D preconception because that is the one thing which has some benefit in improving the pregnancy or live birth outcome. So screen thyroid function in all RPL evaluation is part of the entire armamentarium of investigation, and treatment definitely improves pregnancy outcome. Final question to Dr. Monisha. Thank you, Dr. Gomati, for that clarity.
Thank you.
Dr. Monisha, 30-year-old woman, 3 miscarriages, all investigations normal. Is this good news?
It's a case of unexplained infertility.
Unexplained RPL. And is that reassuring for ourselves in the first place?
Ourselves, we will not be able to come out for the diagnosis, but we can reassure the patient that 50% experience unexplained RPL.
So in terms of monitoring, it is better because we don't have to do anything specific intervention. Yeah. Should progesterone be used empirically? And what counseling should be given for this patient?
For the recurrent pregnancy loss cases, it is better to use progesterones because we have the large RCT which is available, the PROMISE trial, and it supports the micronized progesterone's 400 milligram BD dose.
Yeah.
And vaginal route is preferred. So it is always better to use the progesterone in recurrent pregnancy loss cases.
Yeah. And there is one thing on high doses of IV immunoglobulin, 400 milligram per kg for 5 consecutive days early in pregnancy, with a significant increase in the live birth rate, but that's only one RCT. So progesterone is definitely used empirically. It has been given by all the evidence bodies along with CGPR or FOGSI as well. So the rest of it are not recommended at all. I've clearly put it. Lymphocyte immunization therapy, glucocorticoids, intralipid, heparin, IVF, PGT, not on a routine basis. There was now a trend for endometrial scratch, also to improve the conception as well as prevent RPL. None of these are evidence-based and none of these are routinely recommended in the management of unexplained RPL. The only thing, as we know, is TLC. So it is very, very important to counsel and offer the psychological support. So in general, prognosis very good and live birth rate of nearly 70% even without targeted therapy, just with reassurance and progesterone in the early period. I'm not going to go to the further cases because of lack of time. I'm going to skip all this. And sorry. I've just put together the various guidance which are available and what ESHRI and RCOG have been debating with regards to the management. As we already mentioned, RCOG relies on 3 or more, whereas ESHRI and ASRM rely on 2 or more. Same testing for antiphospholipid antibody syndrome. We do not routinely regularly check for inherited thrombophilia. ESHRI recommends cytogenetic analysis, recommends uterine assessment by 3D ultrasound or hysteroscopy, recommends thyroid function and TPO antibody, and do not recommend any specific testing like HLA, NK cell, etc. beyond research perspective. And similar advice regarding lifestyle, optimizing BMI, smoking cessation, limiting alcohol and caffeine. That is something for us to note as well. Treatment for antiphospholipid antibody syndrome, offering aspirin and heparin until 34 weeks at least from positive test, progesterone supplementation with recurrent pregnancy loss and early pregnancy bleeding, 400 milligram micronized vaginal progesterone twice daily until 16 weeks. There is no mention of HCG injections and supportive care. So both the bodies agree pretty much. So in summary, for genetic defects, offer genetic counseling and pros and cons of PGT to be discussed. Antiphospholipid antibody syndrome, aspirin before conception, low molecular weight heparin to be added after positive pregnancy test, and carry on. Uterine anomaly, only if it is septate, offer surgical correction, perform a 3D ultrasound with a good sonologist. Cervical insufficiency, serial surveillance and pregnancy, cerclage in a selective manner in selected indicated cases. Thyroid problem, levothyroxine and anti-TPO positive, then definitely treat. High sperm DNA fragmentation, a PIXI or an antioxidants, no role, mainly lifestyle changes. ANA positive, no specific treatment. These are not inherited thrombophilia or problems like this. Unexplained, definitely consider vaginal progesterone and consider IVIG if more than 4 losses. The rest of the management are not evidence-based intervention. These are some of the gray areas where a lot of interventions have been advised, but we still do not know what the exact way forward is. So we have to start investigation after multiple pregnancy losses, encourage healthy habits, provide clear information, and recognize that many couples may not even exhibit a clear cause. So, as take home, RPL affects 1 to 2% of the couples. Chromosomal abnormalities most common, APS most treatable cause. We correct the uterine anomaly surgically if it's septate uterus, screen and treat endocrine disorders, and many cases which are unexplained, but the prognosis is favorable. Again, harnessing your support and solidarity for Sampath Kumari ma'am, who is our Foxy presidential candidate, and thank each and every one of you who have been present here to show that support and participated actively in this webinar. Thank you once again, counting on you.
Thank you, Dr.
Thank you.
Meera. Yes,
Thank you, madam.
Thank you all. That was wonderful. Thank you.
Wonderful panel, as usual, Dr. Meera, and our wonderful panelists, Komati, Monisha, Meenal, Shravani.
Very
And,
clear messages. Thank you so much. It was very, very engaging.
But Falguni Thakur has left. Yes, Radhika Gauri is here. Can you give the vote of thanks?
Yes, ma'am. I'm here. Thank you, Sampath ma'am. Thank you for the opportunity. It was a wonderful meeting and a very good message to all our Foxy people. And I thank Anjalakshi ma'am and our chief guest and Dr. Amala ma'am, who both kindly participated in the meeting in amidst their busy schedule. And I thank all our society presidents from various places, mainly Udaipur, Dr. Sudha Gandhi ma'am, and Dr. Nalini Sharma ma'am, Dr. Saroj Jain, and Dr. Ritika madam, and Dr. Padma from Rajamundri Society, Dr. Hiral Pandya, Dr. from Madam from Baruch Society, and our moderator, Dr. Meera Raghavan ma'am, who took her time and did a wonderful job. And I thank Dr. Falguni Thakur, Dr. Meenal Shuk, Dr. Shravani Vinjamuri, Dr. Gomati madam, Dr. Monisha, and so I thank all of you for giving your valuable time.
Radhika, 1 minute. Dr. Nalini Sharma has joined, I think. Previously, she was not there. She was the secretary of Udaipur Society. Dr. Nalini Sharma, can you tell few words? Dr. Nalini?
Good evening, ma'am. Ma'am, I am not able to start my video actually.
No problem. No problem. What happened? Sahiti, why don't you help her?
Yes, ma'am. I just requested her to start the video.
Yes, now she has opened, I think. Yes. Yes,
Wonderful
Dr.
panel.
Welcome.
Wonderful panel, Dr. Meera, ma'am. These
Thank
were
you.
some very crisp take-home messages. And we look forward to such, scientific deliberations as ma'am is going to lead forward with the election which is going to be there, because I
Thank you,
think
ma'am.
these are the root cases that a gynecologist day in and day out is actually facing, and we need the updated knowledge regarding the guidelines which are there. So wonderful session, ma'am. Thank you so much. It was really helpful.
Thank you, Dr. Nalini. Dr.
Thank you, ma'am.
Gandhi has messaged that she is in US, I think. That's the reason she couldn't join. She was the president of Udaipur.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Regards from Sudha Gandhi, ma'am, as well, because she's outside, so she's not able to join actually. So, best wishes from Udaipur Option Gynae Society, ma'am.
Yes, I was supposed to come somewhere or other. It is going on missing. So I thought at least we will do the webinar. What happened to
Definitely,
the Jodhpur
ma'am.
cases settled?
Which one, ma'am?
Some cases there was a problem they were telling. Though Jodhpur was also supposed to join, but some maternal death problem, something they were.
Okay.
That's the reason they couldn't join. No problem. Anyway, thanks to Dr. Nalini and Dr. Yes, Radhika, you can continue. Baruch
Yes,
Society.
So thank you so much for attending, and thank you, Sahiti, and Dr. Madhumita also. Thank you, and she has organized all the as per Madam's advice. Thank you so much, and thank you, Sri Priya, for helping in the organizing this meeting.
Thank you, Sakiti. Okay, Radhika, thank you for being the MOC, and thanks to Alwar, Baruch, and Udaipur and Rajmundri Society for participating. Thank you, Dr. Nalini, being there for the last minute, and our panelist, Dr. Meenal. Good interactions, I think. Dr.
Yes.
Meenal, Dr. Padmini,
Yeah.
Dr. Monisha, Dr. Shravani, Dr.
Gomati.
Pomati, and
Wonderful.
teacher, Dr. Meera Raghavan.
Adam.
Wonderful
Okay.
Very
discussion.
interesting
Wonderful
panel.
panel.
Yes.
It will be
Thank you.
available in the YouTube. If Sakiti, you post the link in the group, whoever has not attended, they will see the YouTube link. Thank you,
Yeah.
all of you. Good night. And
Thank you,
again,
ma'am.
I request
Thank
all
you,
of you
ma'am.
to vote for me. Thank you.
Thank you, ma'am.
ma'am. Thank you.
Please
Thank
vote
you,
for
madam.
us. We will all vote for
Thank
you.
you.
Thank you.
Yes.
Thank you.
Thank you.
Thank you, ma'am.
so
Yes,
much.
ma'am.
Thank you, ma'am.
Thank you, ma'am. Good
Thank
evening.
you.
All the best, ma'am.
Thank you, Dr. Meenal. Thank you.